where we left off last time. Thank you on Monday for being patient with my weird voice. I appreciate it. It was still weird on Tuesday when I was in Zoom meetings, but this morning I woke up and I feel fine, so we're good. Whatever. I mean, I spend my day talking to 2-year-olds most of the time, so it doesn't really matter if I don't have a voice. It's only like 1 hour when I come here that I really need to have it. So I'm glad I have it back. We were talking about Campylobacter. And Campylobacter, normally we talk about it as a GI pathogen, so of course we're expecting things like diarrhea, maybe some nausea. Depending on the species of Campylobacter, sometimes we can get those ulcers that form in the intestines and we can have bloody diarrhea in the patients. But one of the weird things that is sometimes associated with Campylobacter infection is the development of an autoimmune condition called Guillain-Barré syndrome. This is where the immune system basically attacks the peripheral nervous system, so it causes complications up to and including things like paralysis and difficulty moving. So the question is, why? Why do we sometimes see that following this infection, we have patients who develop these autoimmune complications? And generally the reason for that is that Campylobacter has some molecules on its surface that look a lot like molecules that are found in our nervous system. And what will happen is when our immune system is mounting an immune response against Campylobacter, in some of our patients, you get cross-reactivity, where the antibodies that were generated in order to fight the Campylobacter infection actually will target the host as well. It's a rare complication, but it happens often enough that scientists have been able to identify that this is what happens following some patients' infections with Campylobacter. Along those same lines, because you do develop that cross-reactive immune response, you also have some patients who can develop arthritis following a Campylobacter infection. So even if it was a GI infection, that immune response that looks like that autoimmune response can cause arthritis as well. So it really is just if you were unlucky enough that your immune system mounted an immune response against a particular antigen on Campylobacter that looks a lot like your own cells. So here we have a clinical history of a woman who developed Guillain-Barré after an episode of Campylobacter jejuni enteritis. So she had a week of fever, watery diarrhea, nausea, abdominal pain, weakness, fatigue, right? That's what we expect. But after that, she then developed slurred speech, which is kind of strange for a gastrointestinal infection. She was taken to the hospital where it was noted that she was unable to speak, though she could write coherently and she was oriented, so she wasn't confused. They weren't thinking stroke at this point. She had some numbness around her mouth, bilateral ptosis, like the eyelids were drooping. She couldn't open her eyes all the way. That's what ptosis is, so it was in both eyes. And facial weakness, and her pupils were non-reactive. So normally, like you shine light in somebody's eye, the pupils will close up, and then you take the light away, the pupils will open up again. Neurological examination revealed bilateral muscle weakness in her arms and chest. So again, that bilateral nature of the weakness, the bilateral drooping of the eyelids is like counter to what we would see with a stroke. Typically with stroke patients, it affects one side of the body or the other. So she's having these symptoms on both sides. On the second day, the weakness extended to her upper legs. On the third day, her mental status was normal, but she could only move her thumb minimally, and she could no longer lift her legs. Sensation to light touch was normal, so she could feel if you would touch her, but the deep reflexes were absent. Campylobacter was recovered from this patient's stool culture at the time of admission, and a clinical diagnosis of Guillain-Barré syndrome was made. Despite aggressive medical treatment, the patient had significant neurological defects 3 months after discharge to a rehab facility. This woman illustrates one of the significant complications of Campylobacter enteritis. Once you have that immune response that has been mounted against your body, you can't really get rid of it anymore. You can try to ameliorate the symptoms as much as possible, most likely through giving immunosuppressive drugs, which is what you give to pretty much any patient that has an autoimmune condition, like people who have rheumatoid arthritis and things like that. They take immunosuppressive drugs. But you see that even months after clearing the infection, months after treatment, she still experienced all of those symptoms. Campylobacter can be diagnosed through microscopy of a stool sample, usually a concentrated stool sample, immunoassays, or nucleic acid assays. Culture is difficult. Remember, we talked about this right at the beginning of talking about Campylobacter. They grow, weirdly enough, in the lab better at 42 degrees than they do at 37. And most of the time, when you're thinking you're trying to isolate a bacterial organism from somebody's stool, you're going to default to incubating at 37, just in your standard incubator. Things like all of the Enterobacteriaceae are going to grow under those conditions. But Campylobacter requires lower oxygen levels and higher temperature to grow in the lab. It's also a little bit more slow growing than some of our Enterobacteriaceae, 48 hours or more. There is no vaccine available, but antibiotic therapy can help clear the infection. Most strains are just inherently resistant. This is not, there is some acquired resistance, but just in general, they're resistant to penicillins, cephalosporins, and sulfonamides. So you have a lot of things you actually can't use. So it can be really important to try to diagnose specifically that your patient has Campylobacter, because some of those drugs will work against other species, but they won't work against Campylobacter, so you won't be helping your patient. And of course, the best way to avoid any foodborne illness is to properly prepare your food. Wash your hands if you've handled raw dairy or meat products. Thoroughly cook all of your meat or eggs, and pasteurize your milk. Don't drink raw dairy. That's basically the way that we do that. We are starting to see increases in acquired drug resistance in Campylobacter. The CDC considers it a serious threat. An estimated almost 450,000 infections per year and 70 deaths from drug-resistant strains. And so these cause diarrhea, fever, abdominal cramps, and sometimes complications like irritable bowel syndrome, paralysis, and arthritis. So it's one that you don't want to have. You want to get rid of as quickly as possible. Okay, questions about Campylobacter before we move on to Helicobacter. Okay, well, I promise we'll jump out of the GI tract after Helicobacter, but we're going to be in the GI tract for just a little bit longer. So Helicobacter look a lot like Campylobacter under the scope. They're not necessarily spirochetes, but they do have kind of a spiral-ish shape. Spirochetes tend to be even more curly. There are a handful of species associated with human disease, but really the one we talk about the most is Helicobacter pylori. That is one of the causative agents of stomach infections. So this one will actually, this is not intestinal, this is stomach, in the stomach itself, and can cause things like inflammation in the stomach lining, ulcers, and even has been associated with cancer. It's one of the few bacteria that's associated with causing cancer. So that's the one we're really going to talk about.
I don't see these on Canvas.
Oh.
Me neither, yeah.
I thought I put them up. Oh, I just didn't hit publish on the module. They are uploaded, but I did not hit publish. So now you should see, if you just refresh, there should be a bunch up there. Okay. So the species is highly motile. They have polar flagella. They are urease positive. Remember, we did the urease test in bacteriology. What does that test do? What is it? What is the point of making urease? Why would a bacterium do it?
It converts something to excrete something from the body.
It's involved with, it helps to neutralize pH. It involves processing of nitrogenous compounds. Yep. And so the enzyme itself helps them to at least partially neutralize the stomach pH. Because remember, the pH of the stomach is very, very acidic. So how does this organism actually live in and cause an infection in the stomach? Partly it can cause this little localized area of a more neutral pH. But it can also block stomach acid production in the local area. It is catalase and oxidase positive, so those are other tests you could do to verify that you have the organism. And of course, catalase can be important as an immune evasion mechanism. They don't actually have a lot of immunogenicity just by themselves. Most gram-negatives do. The LPS can stimulate the immune system because of that endotoxin, right? The lipid A component of LPS is generally a potent immunogen, but for whatever reason, the LPS of Helicobacter is not as immunostimulatory. So evolutionarily, that could provide a benefit that, they're not triggering the immune system as much. So it, in theory, could provide a type of immune evasion because they're not stimulating an immune response, which would allow them to stay and cause an infection in that local area.
So that's the LPS specifically for Helicobacter?
Yes, the LPS specifically of Helicobacter.
So, and then I was just going to confuse because if it's urease positive, that means it can metabolize urea, but the main acid in stomach acid is hydrochloric acid. How does that help balance pH?
It can break down other nitrogenous compounds, and it produces ammonium as a byproduct. So it's a basic compound as a byproduct. If you took my bacteriology lab, this was my favorite test because it was hot pink and they were positive. But yeah. The O antigen resembles blood group antigens. So this is another way that helps them to evade the immune system because the O component of their LPS basically looks a lot like blood antigens, so the body won't necessarily mount an immune response because it looks like self. So we call it molecular mimicry when an organism can mimic something found in the human body. They are difficult to isolate in culture. They're very small, just like Campylobacter. They require low oxygen. And you don't usually get them to super, super high numbers, so it can be difficult to pull them out of the stool. Some of the virulence factors, so if you think about your stomach, right, generally we picture our stomach as kind of a sack full of acid that helps us digest our food. Well, how does the acid not digest our stomach? We have a nice layer of mucus that can coat the tissue of the stomach and protect it from being degraded by the acid. This bacterium has an enzyme called mucinase that allows it to kind of burrow through the mucus and get even more away from the acid and be right there next to the layer of tissue. So it can break down the mucus. It has phospholipases for tissue destruction. It has a toxin called vacuolating toxin A, or VAC-A, that also helps it to kill host cells. It has a gene called cytotoxin-associated gene, and it has a pathogenicity island. So it has, instead of a type 3 secretion system, which we've talked about before, it has a type 6 secretion system, which looks really similar. It's still that type of syringe mechanism, but it's made of different proteins, and evolutionarily it has a different origin. And they also can induce IL-8 production to kind of trick the immune system. So they have a lot of different virulence factors. And actually this bacterium, in terms of how long have we known about it, is not all that long. It was first isolated in 1984, and there were a couple of scientists in Australia, one of whom for sure was awarded, or at least partially awarded, the Nobel Prize in Medicine in 2005 for his work with this bacterium. And I'll tell you why in just a minute, and also tell you why you should never try to win a Nobel Prize that way. It is estimated that in developing countries, so countries that don't have the same level of infrastructure for sanitation, that between 70 and 90% of people are colonized with this organism, and that the number is less than 40% of people in the US. Now, one of the really weird things about this bacterium is it is found in almost every patient that has stomach ulcers. And so the mechanism for that seems to be that because it degrades mucus of the stomach lining, that allows the acid to come into contact with the stomach lining and burn it, causing ulceration. And so we have this, situation where the bacterium is not, and it can also cause tissue damage, but it's not just the tissue damage caused by the bacterium itself, but because it kind of degrades that localized area and can allow the stomach acid to get closer. But kind of counterintuitively, what we tend to see is that patients who have stomach ulcers because of Helicobacter generally don't get heartburn. So heartburn is acid reflux, and what's happening is your stomach acid is going up into your esophagus and burning your esophagus. That's why they call it heartburn, because it feels like it's your heart, because it's right back there, and it burns because it's burning. In patients who have chronic acid reflux, they have a relatively high rate of cancer development in the esophagus. And if you think about it, it makes sense. You have constant tissue damage in the esophagus. The esophageal tissue and cells are constantly replicating to try to replace and fix themselves. The more you replicate, the more rapidly you replicate, especially if you're just trying to close up some wounds, the more likely you are to make mistakes. And so in patients that have chronic acid reflux, it sounds like, well, it's just inconvenient and you're kind of in pain, but oh well, they actually are at much higher risk for developing cancer in the esophagus. But if you have ulcers, it seems to be protective against acid reflux. But we'll talk about why you also don't want to have ulcers. You want neither of these things. You do not want acid reflux, and you also don't want stomach ulcers. It is a fecal oral bacterium, so we often can avoid it just by cooking our food, washing our hands, all of those lovely things. So I'm going to tell you how you can win the Nobel Prize in medicine, but how you absolutely should not try to win the Nobel Prize in medicine. So in 1984, 2 Australian physicians reported a discovery that completely changed the approach to treatment of stomach infection and peptic ulcer disease, as well as set the foundation for the understanding of the cause of gastric cancers, both gastric adenocarcinomas and mucosa-associated lymphoid tissue lymphomas. So both lymphatic cells, like the lymphoid cells, cancer of those, or cancer of the tissue of the stomach. In an analysis of gastric biopsy specimens from 100 consecutive patients who came for gastroscopy, they demonstrated curved gram-negative rods resembling Campylobacter in 58 patients, so well over half. The bacteria were observed in most patients with active gastritis or inflammation in the stomach, gastric ulcers, and duodenal ulcers, so it can get into parts of the intestine as well. Although similar organisms were observed associated with gastric tissue 45 years earlier, this report stimulated resurgence and investigations of the role in this new organism in gastric disease. Despite the skepticism that greeted their initial report, the significance of their work with Campylobacter was recognized when they won the Nobel Prize in Medicine. So you're like, well, what did they do that makes you say we should never do that? Well, one of the ways that they tried to demonstrate that these bacteria were the cause of the ulcers is that Marshall drank it. He grew up a culture of Helicobacter pylori, and he drank it, and within days developed symptoms of gastric ulcers. Do not drink the bacteria. Okay. So he did, but he won the Nobel Prize. So the disease that a patient will experience when they're infected with Helicobacter is related to the site of infection. Is it in the stomach? Is it in parts of the intestine? 10 to 15% of patients who develop gastritis, so inflammation in the stomach, will develop peptic ulcers. So not every patient who is exposed to Helicobacter is going to develop gastritis. Not every patient who develops gastritis is going to develop peptic ulcers. But it does very much follow that patients with peptic ulcers almost certainly have Helicobacter. It is responsible for 85% of gastric and 95% of duodenal ulcers. So what causes the other 15 and 5%? I'd argue mostly Helicobacter that just hasn't been detected. But there could be other conditions that could lead to it too. It's just very uncommon. So then you have the increased risk of gastric cancer. So just like I talked about with the esophagus, where it's constantly being burned and constantly trying to repair itself, you can develop cancers. You can see the same thing that can develop with stomach ulcers. So some of the first symptoms that a patient with Helicobacter pylori infection will experience will include bad breath. So because of the neutralization of the stomach acid, just that change in the pH of the stomach acid, it leads to the ability to kind of smell the food that's digesting a little bit, so people can have really bad breath. You could do histology of a gastric biopsy. There's a particular stain you can do because these are so small. This type of silver stain can highlight these really tiny little organisms. Test for the presence of urease, and of course do immunoassays. Culture is difficult because they do grow relatively slowly compared to some other bacterium. They have selective growth requirements, so you can try to generate the appropriate media. If you have a patient that has a peptic ulcer and you really want to try to culture, you can make the media appropriate for culturing Helicobacter. You can look at them under the microscope, and then of course oxidase, catalase, and urease tests are all going to be positive. For most patients, you give them a proton pump inhibitor that helps to reduce acid production, which sounds counterintuitive. You're like, wait, this bacterium likes it when you don't have stomach acid, but at the same time, the acid is what's causing your ulcers. So the proton pump inhibitor helps to decrease acid production in the stomach so the patient can recover from the ulcers. And then combination antibiotic therapy, generally with a macrolide and a beta-lactam, is going to get rid of the bacteria. So that will allow the patient to heal and clear the infection. Okay, questions about Helicobacter? You guys know the comic The Far Side? Like it's like a actual comic that was the comic strip in the paper. There's one that like pretty much every microbiology lab somewhere has it hanging up, and it's all these scientists in the lab, and one guy's holding a flask, and he goes, "Lemonade, what happened to my culture of amoebic dysentery?" And then there's another guy in the lab coat in the back like drinking, going, and that's what I picture was going on in that lab, is that they were like drinking the thing like, oh, whoops. So no, they did it on purpose, but don't ever do that.
So Professor, it's pretty like a dangerous bacterium? So it's pretty like a dangerous, or?
I mean, The majority of patients probably won't develop any symptoms at all. And the ones that do, the major symptom is just inflammation of the stomach. But once you start developing ulcers, it's really hard to get rid of them without this treatment. And then having chronic ulcers puts you at risk for developing cancer. The majority of patients who get Helicobacter are not going to get cancer. And the majority of the patients that have an ulcer are not going to get cancer. But it is correlated.
So essentially, if you have a Helicobacter infection, you should be getting like antibiotic treatments for it?
Mm-hmm.
Oh, interesting.
Uh-oh. Do you know somebody who has Helicobacter that hasn't been getting treatment?
My dad.
Come on, Dad.
Well, his doctor didn't give him any medication, so I don't know.
Oh, that's always fun.
Yeah, I was like, I recognize this, so I went to look at his doctor charts, and it says that he has a Helicobacter.
Hmm. Hmm? Maybe they're hoping he'll clear it on his own. No. If I have a diagnosed bacterial infection, I'm like, no, I would like treatment, please. Thank you. If you don't know what it is, I guess. Oh. Okay. So this section is called miscellaneous gram-negative rods. They're not gastrointestinal, but it's really hard to classify them otherwise. They're all gram-negative, so they're miscellaneous gram-negative rods. And the first group that we'll talk about is Bartonella. So Bartonella, the species Bartonella hensley, is associated with a disease called cat scratch fever or cat scratch disease. There's also a song called Cat Scratch Fever, so you can listen to it if you want. I don't think it's about this infection. I actually don't know what the lyrics are, but I do know there is a song called Cat Scratch Fever. So these are short gram-negative rods, so they can have that kind of coccobacillus morphology. They're not like elongated like some of the other ones. They have pretty strict growth requirements, so they're not easy to grow, and they do have a long culture time. So again, we call it cat scratch fever because it is often associated with cats. They tend to carry it sometimes as a GI pathogen, but they get it on their feet, and then if they scratch you, you can potentially get the infection. So often what we see is swollen lymph nodes, and so this is an 8-year-old patient with cat scratch disease, and you can see that she's got 2 very swollen, noticeable lymph nodes. It can lead to serious nervous system and cardiac complications, but it also can lead to this angiomatosis. It's basically like this kind of like pocket of blood vessels that start to develop really weird that you can see on the skin. But not a terribly common infection, can be treated with antibiotics. But this one I thought was kind of interesting. A woman loses her eyesight after her cat licks her. So I know cats have that weird like sandpapery tongue, and it does feel like you've been blessed if a cat decides to like come by and give you a little lick. If they do it on your eyeball, probably I wouldn't recommend that. And I guess like her and her cat, like it was their regular thing. Like he would come up and like on her eyeball, and she let him. And she got the infection in her eye, and of course she lost her eyesight. So, just in general, I know the cats do whatever they want, but try not to let them lick you in the face. So this was the first Bartonella case. It was described back in 1990, and it was first found in an HIV-infected patient. So this is not something that we classically see in most patients who are immune competent. Tends to be in patients who are immune compromised, or the bacterium gets into what is supposed to be relatively protected area of your body, like your eyeball. So this is a patient who is a 31-year-old man with advanced HIV infection, high fever, chills, sweats, and weight loss. Blood cultures were negative after 2 days. Despite an initial response to oral antibiotics, the fevers returned after 2 weeks. He had very low cell counts in his blood, elevated liver enzymes, so that means there's something going that's stimulating the liver, which is generally not good. The only abnormality they could see in his body by a CT scan was that his liver was enlarged, which is not good. All diagnostic tests were negative until after more than 2 weeks of incubation. Gram-negative rods were recovered from the blood cultures. Subsequent studies characterized this as a newly discovered organism. It was called Bartonella henselae. The patient was treated with erythromycin, and despite recurrent fevers, became culture negative. This indicates the susceptibility of HIV patients to this organism, the insidious onset and prolonged course of the disease. It takes time for the symptoms to develop. The symptoms are relatively nonspecific sometimes, unless you do notice those swollen lymph nodes, and the culture took 2 weeks. So luckily they kept the plates growing because the patient responded to antibiotic therapy. And I'm sure that the idea was, oh, the patient's getting better. At least they didn't throw away the plates. So they kept them to see what would grow. Okay, the next member of this genus is Bordetella. And I promise I don't have it. Bordetella, the species we worry about most in humans, is Bordetella pertussis, which causes a disease called pertussis, or sometimes we call it whooping cough. There is another species, Bordetella parapertussis, that causes a more mild form of whooping cough. There's Bordetella bronchoseptica. If you work with dogs, you've probably heard of kennel cough. That's basically the doggy equivalent of whooping cough. It can sometimes be transmitted to humans, especially those who are immune compromised. But again, the one that we worry about the most in humans is Bordetella pertussis, which is the causative agent of the disease we call whooping cough. So it has a number of different virulence factors. It's able to adhere. It has necrotic toxins that cause cell death. It has a toxin called tracheal toxin, which inhibits the cilia. And remember how important the cilia are for moving stuff out of your lungs so that you can continue to breathe and don't get a really nasty infection. So it inhibits those cilia. And then there's pertussis toxin, which causes an increase in cyclic AMP, just like we see with cholera toxin. But in the lungs, that causes increased mucus production, increased it's secretions of mucus in the lungs. So now you have this combination of cells are being killed by the necrotic toxin, the cilia aren't working because of the tracheal toxin, and now you're producing mucus that is filling up the lungs that you can't get rid of. So it's a really dangerous combination of all of those things. And so I have this video. I hope the sound works. So this is a pediatric patient with whooping cough. Oh, good. The sound will work. So the reason they call it whooping cough is because after a coughing spasm, the patients are they're not able to breathe, so they're trying to catch their breath, and they have that deep inhalation of air trying to breathe. And so I chose a pediatric patient instead of like a neonatal patient because I found that like way too disturbing. Even before I had kids, like watching a baby with whooping cough was like not pleasant. It's not pleasant to watch the kid either. But he ended up being okay after this. The problem with, like, again, that coughing, they can't breathe. They're choking on their own mucus that's stuck in their lungs that they can't clear. And the coughing can be so violent that patients will often vomit and have even been demonstrated to, like, break their ribs from the violence of the coughing. So it's not just you have a cough. So it's a very, very severe disease. What we tend to see with the patients is a 7 to 10 day incubation period. So it is a respiratory infection. Between 7 and 10 days after exposure, the patient will have no symptoms. Symptoms begin 1 to 2 weeks after the initial infection. And it looks a lot like a cold. So they have a runny nose, they're tired, they have a fever, they're sneezing, and they might have a loss of appetite. And then you have the paroxysmal stage, which is where you have that whooping cough. You can have vomiting, white blood cell destruction because of that toxin. It kills cells, so it can kill white blood cells as well. So like the macrophages that are supposed to help clear it up. And when patients, if they survive, they'll enter a convalescent phase where the coughing will get less and less, but they're at risk for secondary complications, things like pneumonia. If it has gotten into the bloodstream, you can see things like seizures or encephalitis. So it's not a mild infection, especially in children. So this was a pertussis outbreak in healthcare workers. The index case was a nurse anesthetist and presented with the coughing followed by vomiting and episodes of not breathing that led to a loss of consciousness. Like she couldn't catch her breath. She literally passed out because she couldn't breathe. Surgical service personnel and exposed patients and family members were surveyed with cultures, PCR testing, and serology obtained from patients with respiratory symptoms. 12 healthcare workers, but 0 patients, at least, developed clinical pertussis. The lack of disease in patients was generally because people around them would wear masks. They have cough etiquette and limited face-to-face contact. So apparently, like in the nurse's break room or the doctor's break room, everybody's nasty. That's what it sounds like to me. But at least they kept their patients safe. This outbreak emphasizes the susceptibility of adults to infection and the highly infectious nature of Bordetella pertussis. So it has fastidious growth as well. It's relatively difficult to culture, not impossible. The nucleic acid or immunoassay tests are going to be the best way to diagnose it though instead of culture, but that cough is also very diagnostic.
So Professor, who have asthma, so this would be really hard for them, right?
Oh yeah, absolutely. Any sort of other respiratory complication is going to make this much worse.
And it's also like when one person have it, the other person will get it too.
It's pretty contagious, but what we'll see in just a minute is there is a vaccine. But this is the reason that they will highly recommend that pregnant women and anyone who's going to be around the newborn for the first 2 months get the Tdap booster. They're not worried you're going to give the baby tetanus or diphtheria, really. They're worried you're going to give them whooping cough. Yeah. So macrolides and other antibiotics can be helpful, but they're usually not given early enough because by the time that the symptoms have developed and the physicians are aware that this is whooping cough, the patient already has all that toxin that's been produced, and so they already have all of that mucus buildup and everything. Now, again, the vaccines are available. It's the AP part of the Tdap or DTaP. It's acellular pertussis, so it's like components of pertussis bacterium, not a whole bacterium, and definitely not living. What we have seen because of vaccination in the US, this is just in the States up through 2021, a relatively significant decrease in the amount of pertussis diagnosed in the States. Before the introduction of the vaccine, looking at anywhere around a couple 100,000 cases per year. When the first vaccine was introduced, you could see that started to drop until almost zero. In the 70s, 80s, 90s, people stopped vaccinating again. This was right around the time that everybody thought vaccines caused autism. So they stopped vaccinating, so we see an increase, but it looks like potentially people are starting to vaccinate again. So we're seeing decreases in the cases of pertussis again. This graph is similar to the last in that it shows like the pertussis case rates, but what we're really looking at here is patient age groups. So the green line at the top is children under the age of 1. They are most susceptible to disease, and that is why adults should get vaccinated. Children don't get vaccinated against pertussis until 2 months, those that follow the CDC recommended vaccine schedule. And children under the age of 2 months are very, very likely to die of whooping cough. After that, they have been vaccinated, so it's less likely that they will die, but it's still very dangerous. So our pediatric patients are the ones we worry about the most. And then as we get older, nobody really cares, right? Nobody cares about you once you're, what's the Blink-182 song? When you're 23, nobody likes you when you're 23, nobody cares. 20 plus, right? Okay, adults get it most often because not that they haven't been vaccinated, but they haven't been boosted. Immunity can wane. And so if an outbreak happens, I'm sure all of those healthcare workers had originally been vaccinated, but had they kept up with their boosters? Maybe not. Okay. Questions about Bartonella or Bordetella? Yeah.
Were these named after the people that discovered them?
Mm-hmm. Yeah. Either the people that discovered them, a lot of times these bacteria are named after the people that discovered them, or like microbiologists they admired. Yeah. So this genus as well, Francisella, is named after a scientist, but the species we'll talk about in just a second is named after an area. So Francisella is a genus that not a lot of people are super familiar with, but it is important because it's a potential bioweapon. So the DoD, the Department of Defense, does a lot of work with this organism. So it's a very, very small coccobacillus. They're non-motile and they have a thin capsule. So the capsule helps them, of course, evade the immune system. They're relatively slow growers, 3 days or more till you see a colony. But one thing that they do that, again, helps them to evade the immune system is they go intracellular. And they can replicate inside of macrophages. That's what that notation means. Neutrophils, epithelial cells, and endothelial cells. And so the species that we worry about, that is the more dangerous species in this genus, is Francisella tularensis. And so I told you the species is named after a place. It's named after Tulare County, which is just down by Fresno. The other name for this disease is, they'll call it rabbit fever, because it's often a bacterium associated with rabbits and hares, related species, the lagomorphs. And when it gets into people, in the absence of terrorism, it generally gets into people because they have come into contact with a rabbit, either through like hunting, or like I read one case where the person like ran over it with their lawnmower and they inhaled it that way. I can't even like mentally picture what that had to look like, so I don't want to, but that was the case I read. And it can also be transmitted by ticks. So there are a few different ways that people can get this infection. And so depending on where the bacterium got into the body, that's where you'll see the symptoms form. So if it gets into the skin, you tend to see like ulceration in the skin. You can see inflammation in various glands. If it goes into glands, it can get into the eye. It can get into the mouth. It can get into the GI tract. But what we worry about in terms of bioterrorism and the way that you would ever be able to work on this funded by the DoD is that it can be inhaled. And when it is inhaled, that has a very high morbidity. It makes people very sick. It has a very high mortality. It kills people. And of course, again, it is a potential bioweapon. And so here I will give the plug that the United States does not have a bioweapons program. We do not develop offensive bioweapons. However, we do study all of these things to develop defenses. And that's what the government says. I'm actually not a conspiracy theorist. That's pretty true. It's what we do. But But we know that other countries do have offensive bioweapons programs. So the bacterium itself is difficult to culture. It's slow growing. It's relatively fastidious. Most of the time you would do like an immunoassay to try to diagnose it. Treatment with gentamicin is most common. Some of the cell wall inhibitors like penicillin and cephalosporins are not really effective. So you'd want to pick a drug with a different mechanism of action, not cell wall inhibitor. There are no effective vaccines, but there are groups that are working on vaccines for Francisella. They mostly use closely related strains that are not so deadly. This is, let's see, the other bacteria we've talked about that are the same biosafety level are tuberculosis and plague and anthrax, biosafety level 3. So this is in that same group, biosafety level 3. You have to have special clearance to work with it. You have to have a very specialized facility to work with it. You get all geared up. It's not quite Ebola level. So we're right below Ebola in terms of like how you have to work with it. But there is a strain, a species, that they call the vaccine strain. It's a very closely related species that doesn't cause significant disease, and they're using that to try to develop the vaccine. Oh. And so, the same lab that I worked next to that studied cholera, they also worked on this bacterium, which are not at all related, but that's okay. So one year they made lab t-shirts where they all dressed up in the biosafety level 3 outfits and sat on cholera cots, and that was their lab t-shirt. So I was very, very impressed. But yeah, so biosafety level 3, you won't find this type of research going on at most labs. Most people don't work with this type of organism. But if you're interested in that, government is usually the way to go. We will pick up on Friday with Legionella, which is not named after a person, but is named after a group of old men, the American Legion. It's named after the Legionnaires. So we will meet in lab at 1 o'clock. Again, we have a lot that we're going to be setting up today, but mostly it's just setup. And then we'll do some readings on Friday and Monday because we don't have class next week on Wednesday or Friday. Remember, it's in the syllabus. It's already almost October. Okay? But then after that, unless my kids like take me out, we're going to be good. We're going to be good. Which you may or may not be happy about. You might be like, take her out, but